Hey everybody, Gray Stahlman again. Welcome to The Doctor Is In, live with TOA. It's 2020, hard to believe. This is our second episode in 2020. It's freezing here in Nashville, so I hope you guys are staying warm. I hope you guys are getting ready to watch the Titans win the AFC Championship. Go Titans. Anyway, we've had a long road of talking about various spine topics, and so most of those have been related to the lower back. Today, we're going to talk about some problems in the neck. The topic title was, "My left arm is numb and painful. Am I having a heart attack?" And the reason why I named it that was because symptoms from the neck, such as a pinched nerve in the neck, typically go down the arm. It can be right side, it can be left side, but the biggest deal is that people who are having a heart attack can have left arm pain too. So anyway, we're going to talk a little bit about that and talk a little bit about, like we've done before, anatomy. We're going to talk about treatments for a pinched nerve in the neck and talk about outcomes, okay? So again, as with every episode, this is a work in progress, so thanks for being patient with me. Also remember that while I am an orthopedic surgeon, I'm not your orthopedic surgeon. I want you to realize that this information should be used for educational and informational purposes only. It's not medical advice. If you feel like you're having a problem, seek out appropriate medical care. In addition, I want people to understand that a pinched nerve in the neck is not going to kill you, but a heart attack can. And so I don't want people to think that every single time somebody has pain going down their left arm, that it's only related to the spine. I want people to be aware of that. If you're ever having unusual new pain, particularly on the left side, in the arm, chest, jaw, the thing that can hurt you is having a heart problem, such as a heart attack or what's called angina. And it's always advisable, if to be sure, is to seek out medical care from either your primary care doctor or, in particular, the emergency room. So I just want people to understand that even though a pinched nerve in the neck can cause left arm pain problems, it doesn't mean that all left arm pain problems are related only to a pinched nerve in the neck, okay? So we want to be safe. Anyway, so again, the anatomy of the neck and the lower back are very similar. It's just a little bit different size and a little bit different consequences. You have two bones stacked one on top of the other with a disc in the middle. That's the rubbery shock absorbing pad in the front, and two joints in the back. And in between those two, that stack creates a tube where the nerves run. In the neck, it's even more important because instead of just being single nerves that run down to your legs like in the lower back, it's the spinal cord. The spinal cord is like a giant rope of nerves, of all the nerves that are coming up from your body toward your brain. And so there's more potential for problems in the neck than in the lower back if you have nerve compression. So typically when somebody has a pinched nerve, very commonly they'll not remember any kind of injury, although sometimes they do. Probably the most common thing that people tell me is, "I woke up and I had a crick in my neck." So typically they'll describe pain in their neck, usually in the base of their neck, in the upper part of the shoulder here, which is the muscle called the trapezius. And then many times people will have upper back pain and pain around their shoulder blade. Seems like it's muscular, they try to work it out. Commonly, that is how the nerve irritation pain starts. And then many times we'll see pain or numbness or tingling or even weakness going down the arm. Sometimes it can be mild, sometimes it can be severe. Not everyone with a pinched nerve in their neck has all these symptoms all at once. But the classic description when somebody comes in the office is, "I've got this pain in my neck, this pain in my shoulder blade, and pain, numbness, and tingling going down my arm." that perks my ears up to think maybe you've got a pinched nerve of the neck. So what are the things that can pinch nerves in the neck? Well, basically it's two things. The nerves come out of the spine through a hole that's made up of that stack, again, of vertebrae or bone, disc, and bone. That hole is right around where the joints are in the neck. And so there's one hole on each side at each level where there's a disc. That hole can get narrow because of arthritis in the joints. As joints get older, as they wear down, calcium builds up on those joints and they can get bigger and make that space narrower. Or you can get narrowing from a disc problem, where the disc bulges out or herniates out and pushes back toward where the nerves are. Just like in the lower back in one of our previous episodes where we talked about disc herniation and spinal stenosis and sciatica, that's what you can have in the neck. It's just not called sciatica because in the lower back it's affecting the nerves that go into the sciatic nerve. So this is called cervical, meaning neck, radiculopathy, which means nerve pain or dysfunction in those nerves coming from the spine. So cervical radiculopathy is essentially a pinched nerve in the neck. Okay. Typically the discomfort, pain, weakness, numbness, and tingling follows a very specific pattern down the arm depending on which nerve is being squeezed. Just like in the lower back, we can kind of guess which nerve is being bothered by what location the patient describes their discomfort. We can do that in the neck as well. And so we kind of get when somebody comes in, we kind of get an idea, okay, this is probably a pinched nerve in the neck. We're not sure if it's the narrowing just because of arthritis or because it's a disc herniation or maybe both. Typically when people come in, if it's just been a little bit of time, and this pain can be excruciating. I mean, you may have had it, you may have seen friends or relatives have it, and oftentimes they say, gosh, if I put my hand over my head like this, it feels better. And so we have people walking into the door with their hand over their head. Almost always that's a ruptured disc or a pinched nerve in the neck, okay? So typically we treat the symptoms first. So that's medications, anti-inflammatory type medications, either non-steroid or steroid medications, depending on if your medical history will allow. Pain medicine can be helpful, although narcotic pain medicine is not very effective in addressing nerve pain. Nerve pain is a different beast. We've talked about this in our other episode about sciatica. But pain medicine many times will give people a muscle relaxer to kind of make them less tense, help them to rest a little bit. And then sometimes we'll give people a medicine called gabapentin, which we talked about again when we talked about sciatica, which is a drug that helps to reduce nerve irritability. Physical therapy is typically recommended on the front end if people are struggling and it's fairly new. The purpose of physical therapy is to actually allow us to get the neck moving again and to help take some pressure off the nerves. And we do that by doing traction or doing exercise maneuvers that help open up the space for the nerves to give the nerves a little bit of a break. Cervical radiculopathy often will get better with a little bit of time and these types of management strategies. If people are not getting better, or they're showing us signs of concerning neurologic problems, such as weakness in muscle groups or signs that the spinal cord is under distress, then an MRI is typically the next step. MRI is the best tool for us because it shows us the soft parts, the discs, the nerves, the spinal cord, and the space for the nerves. It also shows us the bone. It's also non-invasive without any x-rays or radiation. If somebody can't have an MRI, such as if they have an incompatible device like a pacemaker or a defibrillator or something else that cannot be used in an MRI, a hip replacement, shoulder replacement, knee replacement can go in an MRI. Spine fusion hardware can go in an MRI. Many pacemakers nowadays can go in an MRI. If they can't get an MRI, we'll do a test called a myelogram and CAT scan. And again, a myelogram is an injection of some dye into the space where the nerves are, into the spine. That dye gets sloshed around by positioning the patient, and then they take an X-ray test called a CT scan or CAT scan, which is another tool, a slicing type tool, to let us get a three-dimensional view of the spine. And then that helps us to confirm the location of the problem that we're suspecting. The most common area we see a disc problem or nerve pressure problem in the neck is between C5 and C6. That's the second disc from the bottom in the neck. The second most common is the one below that called C6, C7. So if somebody's not getting better with their physical therapy and medications and activity modifications in some time, their MRI shows us pressure on the nerves that's consistent with their symptoms, we have kind of treatment option, a couple more treatment options available. One might be the epidural steroid injections that we talked about with the lower back, basically a steroid injection or cortisone shot into the neck to try to reduce the nerve inflammation that's caused by the pressure. Sometimes that alone will help improve or eliminate the pain problem. Sometimes it doesn't. If that doesn't work, then we talk about surgery. And on average, the most common type of surgery for pressure on the nerve, particularly at a single level or maybe two levels, is either from the front or from the back. Now, how we determine how to do that is where the pressure on the nerves is and what the anatomy of the neck looks like. But most people, if it's a ruptured disc in the neck, for example, most people will undergo what's called an anterior cervical discectomy and fusion. Anterior meaning from the front, cervical meaning neck. Discectomy is removal of the disc and the calcium deposits and bone spurs that are there putting pressure on the nerves. And fusion, where we make that space solid. That's been the gold standard of treatment for this kind of problem. It's an extremely effective operation. While it has a laundry list of possible things that can go wrong, in reality, the complications are very uncommon. Infection, being paralyzed, nerve damage are the ones that we worry about the most, but they frankly probably happen the least. The most common things we see as far as a complication is some usually temporary swallowing difficulties because things swell a little bit when we do surgery. Some hoarseness, that's usually related to some swelling or pulling or pressing on a nerve that runs your vocal cords. And some neck pain that increases before it gets better. The one thing that's a little bit nerve-wracking for us is the hoarseness. Some patients can have stretch or pull or compression of what's called the recurrent laryngeal nerve, which helps operate the vocal cords, and that can paralyze or make one of the vocal cords weak and make the voice kind of raspy and hard to project. And usually that's temporary. Sometimes it can be permanent, and that's something we try to avoid, but we know that it can happen. Certainly, for example, if we are operating on somebody who sings for a living, we take extreme care in minimizing the chance that occurs. It still can happen, but we're pretty careful about that in anybody. So anyway, the anterior approach is the most common procedure. If it's done at a single level, most people go home the same day. It takes them a couple of weeks for the wound to heal. Usually their arm pain is either gone or substantially better when they wake up after surgery. Each surgeon is different in how they treat patients post-operatively, but in my practice, typically people are back at work within 6 weeks, usually sooner than that. Usually it's fused together within 3 to 4 months, and people can go on and live their lives. The nice thing about that procedure is it's durable, meaning if you get a solid fusion, I let people to go back to any activity they want without restriction. In a younger person, for example, if I were taking care of a football player, an NFL level player, we will let people go back to playing that level of football in many circumstances, not all, but many. So it actually is a very good tool and a very minimally limiting treatment. Now, some people ask, well, isn't there anything else? Can't you replace a disc rather than do a fusion, which restricts motion in the neck? Actually, yes, we do have man-made disc replacements that are available, and they're useful for very specific people. People who have a ruptured disc in their neck, no real arthritis in their neck, so there's no calcium deposits and breakdown of the joints, where we want to try to maintain as much mobility in the neck as possible. The purpose of the disc replacements is not so much to make normal motion or keep normal motion. What it really is for is to maintain some motion at that disc level so we don't see as much wearing out of the neighboring disc levels above or below the fusion. That's one problem that we have with a fusion. When you take away motion at one level that was meant to move, the others have to work a little bit harder, and we found that they do wear out more quickly. And some of those people need to have further surgery down the road. So the theory behind disc replacement is to maintain at least some motion there to minimize the chance that the next door neighbor will wear out. I think that the data is promising. I don't think that it is, at this point, absolutely perfect. I think that it's a good technology for a small subset of patients. But I think the jury's still out as to whether that's the best thing for all patients. I don't think it is. Okay. Now, can you remove pressure on the nerves from the back? Yes, you can. It's a little bit more challenging because usually the disc herniation the discs are in the front. The disc herniation is in the front, and it's hard to get around the spinal cord from the back. But there are some circumstances where we'll actually do a surgery from the back and make a small window into the spine, remove some of the bone, move the nerve and the spinal cord out of the way, and remove the ruptured disc there. It's a good tool. Again, it's not nearly as commonly done as the ACDF, the anterior cervical discectomy and fusion, but is a tool that is used in some people. Finally, I think that looking at how do we manage this into the future, can we do anything to prevent this type of problem from occurring? And frankly, not really. Most commonly, the reason why somebody develops a ruptured disc or a pinched nerve in the neck is because of degenerative aging-related changes. It's stuff that's out of our control. It happens more commonly than not kind of in the 25 to 55-year-old age group ballpark. Most commonly, it's not related to any specific event. It just starts. And so it's really a consequence of the breakdown of the parts. So I wish there was some easy set of exercises or pieces of advice that I could give people to say, if you do these and avoid these, you won't have this problem. Unfortunately, it doesn't work that way. So anyway, so we've talked a little bit about pinched nerve in the neck. We've talked a little bit about the one major risk of arm pain, left side, that can be bad, which is a cardiac problem. Remember that. We've talked about how commonly pinched nerves in the neck occur, how commonly they actually get better, and we've also talked about various treatments, non-surgical versus surgical. So I hope this has been helpful to you. Our next episode is going to start branching us off into moving toward having some guests. I want to talk a little bit about using some modern biologic technologies in trying to help back pain, primarily low back pain. Talking about stem cells and PRP, platelet-rich plasma, which is our two injection technologies that have been touted, and many people see a lot of this in the news, in being the be-all and end-all for trying to treat all sorts of pain problems in the skeleton. We'll talk about the spine, and then in the future, in March, we're going to bring on one of my associates, Dr. Chris Anderson, who has a lot of experience using particularly PRP in the major joints, like the knee. And I'd like his input on what the data is out there, what the science is out there, and what his experience is with that. He doesn't really deal with the spine, so I'm going to talk a little bit about what we see thus far in the spine, but we'll talk more about his area, which is primarily the knee. So that'll be next week's episode is spine and PRP and stem cells, and then we'll bring Chris on in the spring to talk about PRP in general and stem cells in general, particularly about the other body parts. I think that'll do it for today. Again, if you have any questions, comments, if you're interested in giving us some ideas about how to make this episode or these episodes better, if you'd like topics to talk about, please let us hear from you. You can communicate via Facebook. You can communicate via email. My personal email at the office is stahlmangc, that's STAHLMANGC @TOA.com. If you have some interest in looking at some of the topics I've talked about and would like to know a little bit more, I have a personal website that's really based about my practice on spine, which is Dr. Stahlman Online, DrStahlman online.com. I have a bunch of literature that I've written up that are little pamphlets that I hand out to patients that can give you some information. You can also contact me personally from that website. And certainly if you have any other needs, musculoskeletal needs, orthopedic needs, please go to www.toa.com. You can learn about our practice locations, our services. You can learn about the physicians that we have, including ones you may have seen or ones you may be going to see. You can also make appointments online, and I appreciate your interest. We had an interesting episode last time about chiropractic, and I had a really nice comment by an active chiropractor in Murfreesboro that I'm actually going to take him up on his offer. He offered to have me come down to his office and see how he does things. I would love that opportunity, because anything I can do to increase my knowledge about my field of interest is a good thing. So I'm looking forward to that, and I'll probably report back what we learned, what we talked about. Anyway, have a great weekend. Remember, Titans versus Kansas City on Sunday. Tighten up, okay? Anyway, have a good weekend. Go out there and live your best life.